Hello, this is Dr. Suzuki from Los Angeles, California. I am a wound care surgeon, wound care podiatrist, if you will. I take care of wounds and peripheral arterial disease. I'm here to talk to you about liposomal, which is a lipoprotein apheresis device and how it pertains to a practice and limb preservation strategy. This is my disclosure. And these people are all made in Japan. One is not like the other. One person, Suzuki, is not that famous or accomplished as Shohei Ohtani, but nonetheless, we're all made in Japan. Apheresis filter that we're going to talk about is also made in Japan, used in Japan, in Europe, and in the United States. My background is in wound care. I'm a wound care specialist, wound care surgeon, and one of the things that I do is I go to Japan to give a lecture on wound care, from as north as Hokkaido to as south as Fukuoka, and anywhere in between. So I've been doing that for about 20 years now. One of the things that I notice is in Japan is they use silastazole, which is the vasodilator medication, which is often used after the endovascular intervention. We have really good data that it prevents restenosis after endovascular intervention in lower extremities. And observation number two is apheresis, LDL apheresis. We don't use a whole lot for PAD purposes in this United States, but in Japan they absolutely do. For LDL apheresis, we have 40 years of history. We have about 1.5 million treatments that's already been done in those 40 years. There are five companies worldwide, Kaneka being the leader of the industry. And the main indications FH, familial hypercholesterolemia, but we absolutely use it for coronary arterial disease as well as peripheral arterial disease. That's my specialty here. And that's what the machine looks like. It looks like a dialysis machine, but it's not a dialysis machine. And we'll talk about that. These are table of contents that we're going to talk about. I'll go one by one with you. Hopefully we'll wrap it up in about 20, 30 minutes, maybe less. So let's start with a one patient of mine. So this person, 75-year-old diabetic, he has mixed venous arterial leg ulcer. Very painful. It gets infected from time to time. And because his blood flow is so poor in this area, it just didn't heal. It just didn't heal whatsoever for about 2 years. I was basically seeing him every week. He gets infected from time to time. I give him antibiotics. He gets better, and he just doesn't go anywhere. Vascular surgeon that he sees says there's absolutely nothing he can do to open up the blood vessels because his arteries are completely blocked up. Now, after going back and forth about 2 years with this patient, I somehow convinced him to do lipoprotein apheresis. That's the topic of this conversation. And guess what? The picture to the right, there's excellent bleeding coming through from the wound that was completely ischemic before, it didn't go anywhere. Now it started bleeding. Now we're talking. Now I can do something about this. This is a cholesterol profile throughout the lipoprotein apheresis that he went through. He had 12 sessions, and look at the reduction of the lipoprotein A, which is a cholesterol, and the LDL. Look at that, 97% reduction of cholesterol from high to low. That's pretty amazing drop that you're not going to see with any other medical therapy. And this is what typically you see with a hypercholesteremia and the treatment with it. Let's say this patient started with an LDL of 300, which is you may see with a heterozygous familial hypercholesteremia, which he has. He was given statin. He was allergic to statin. He was given PCSK9 inhibitors, so his cholesterol dropped pretty good. However, his legs PAD was pretty bad, so we decided to introduce lipoprotein apheresis, which dropped his cholesterol down to the teens, like tens. uh, 15. So whole idea is we push his cholesterol way, way, way down to the teens, very, very low level, which basically open up his arteries and the blood flow. And you see the zigzag at the end. You see that because we do these lipoprotein apheresis every 2 weeks, and because the apheresis remove the cholesterol, but body's liver, his liver naturally synthesize more cholesterol. So you're going to see this kind of pushback zigzag formations. But in the end, you're pushing down the LDL, average LDL down to, let's say, 10. That's how you drive the therapeutic effect for the LDL apheresis. Now, going back to the patient, so first visit, it was ischemic wound. It didn't bleed whatsoever, even after cleaning it. 12 session with lipoprotein apheresis. His wound bed is clean and granular. It's bleeding well. So I just took him to operating room and did a split thickness skin graft. Pretty simple split thickness skin graft. He went on to heal uneventfully. 1 year later, he's still healed. He's still walking around. He's still very functional. Although because of his no option CTLI, he was really facing a leg amputation at one point. Okay, so let's talk about PAD. So again, going back to peripheral arterial disease, cilostazol is one therapy, one medical therapy to do vasodilate, open up arteries. Lipoprotein apheresis here, the liposome device by Kaneka. This is another strategy that we can use to dramatically improves peripheral arterial disease. The Let's PAD trial was in Japan, and actually there are multiple trial that shows the efficacy of lipoprotein apheresis for PAD, improved the ABI, improved TCOM number, improved the quality of life. Basically, it reverses the peripheral arterial disease after multiple sessions of lipoprotein apheresis. Again, this is just one trial. There are multiple trials that shows the same thing. I'm going to show you some of the newer studies later in this slide. So let's get back to the basic. Peripheral arterial disease is a lipid problem. Same other coronary arterial disease. Any atherosclerotic disease, ASCVD, those are based on hypercholesterolemia. We have too much lipid that liver produces and not absorbing. We got too much lipid in our body that clogs up the arteries, and eventually it may clog up completely. At that point, you may lose your limb, or you may have a heart attack, you may have a stroke. So these are the lipid problem. And the reverse of it is lipoprotein apheresis, which is the anti-lipid therapy, where we remove the lipid out of your body physically, filter out. Just think of it as a water filter, that the carbon water filter that get rid of all the bad stuff. Just think of it that way. We run through your blood through this machine, which selectively cleans out LDL cholesterol, among other things. Now, this is the updated the guideline coming from European Society of Cardiology of how to treat LDL cholesterol and their target level. Now, I ask you to look at the very bottom of it, of the extreme risk column, which involves polyvascular disease, including PAD, peripheral arterial disease. When you have peripheral arterial disease, we don't think about it, but it's extremely dangerous disease with a very high risk of mortality and morbidity in terms of SCVD. Now, in the European guideline published this year, their recommendation, if you have PAD, the target for LDL should be 40 milligram per deciliter or lower. So that's quite low. So you could only achieve it with a medication, probably multiple combination of medication, statins, ezetimibe, PCSK9 inhibitors, and possibly LDL apheresis throw in there to push it down that low. United States governing body ACC AHA is somewhat little behind on the curve, maybe a little not as aggressive as European guideline, but we all believe that we will probably reach the same level of ambitious LDL target. Basically, lower the better. We kind of know this from multiple studies that came out in the recent years. I'm going to show you one slide. This is the Glogov trial, which was based on one of the PCSK9 agent. So they did a really cool trial. They look at they used the IVUS, intravascular ultrasound, to see the plaque thickness and the volume. And they gave PCSK9 inhibitor to drop the LDL cholesterol way, way, way down. Then they measured the plaques again in the coronary arteries. And what they found is when you drop and push down the LDL target down to 50, 40. When you go down to 40, the plaques actually regress and decrease in size. And with it, when you, let's say this is like about 1% of plaque volume, which doesn't seem like a lot, but which was actually equivalent to 25% reduction in ASCVD event, cardiovascular event. So absolutely absorbing this cholesterol out of your body and regressing the plaques absolutely has implication in ASCVD events. And there was, as you mentioned, that there's another trial that came after this. It's called Pacman AMI trial, which was based on yet another PCSK9 inhibitors. They did the same thing. They used IVUS to look at the coronary plaques, and they basically showed the same thing. When you drop down the LDL down to about 40, you see the plaque regression and the better clinical outcome because of it. This is yet another angle here is semaglutide, the GLP-1 injection that you do weekly. This is very popular in the United States as well as the rest of the country, rest of the world now. It's a commonly, it is a diabetes medication. You give one injection, subcutaneous injection per weekly. What it does is mostly acts on the brain, basically kind of takes out the appetite in your brain, so much so that many of our patients stop eating, mostly lose weight, their glucose improves, a lot of good things happens. And we do know that these medications, these are pharmacologic agents, anti-lipid as well as anti-inflammatory. So much so that we have a data, an actual FDA indication for semaglutide for one of them has indication for reducing the risk of coronary arterial disease, MI, myocardial infarction, as well as stroke, as well as kidney failure, as well as liver scarring or liver failure. So because they're anti-lipid and anti-inflammatory. Now, this is the latest trial. They actually looked at PAD. They took PAD patients with diabetes and they gave semaglutide. What they show was the 13% improvement in walking distance, which we believe translates to increase in blood flow, which they also show with the ABI and everything else. PAD disease progression by 54%. This is again, because it's anti-lipid, anti-inflammatory, you can actually almost not reverse, but you can certainly much improve the PAD. We do not have an actual FDA indication for this yet, but we believe we will get there soon enough. That we will be giving this medication once a week to our patients with the PAD to slow the progression of PAD and perhaps improve the blood flow to their legs. On the contrary, selastozo is vasodilator, so it does actually increase the blood flow. It does actually increase the walking distance, but it does not reverse the. It is not disease modifying because it's just a vasodilator and nothing more. This is the study I published about 7 years ago. I just took 1,000 patients in my wound clinic. I measured their skin perfusion pressure, which is a measurement of their blood flow in their skin, and compare it to how many days it took us to close the wound. What you're going to see is the more blood flow you have, the wound healed. The less blood flow they had, it took them 2 years, 3 years, 4 years to heal the wound. This is common knowledge. More blood flow you have, the faster the wound heals. We know about this. This has been replicated multiple times. This is just happened to be skin perfusion pressure, but we have good data on ABI, TCOM, and toe pressure, and any other measure. And the whole idea I'm showing you this is by improving the blood flow, even just a little bit, even if I push the lever a little to the right, it's going to make a huge difference in the wound healing probability. And for the wound that couldn't even heal, can now heal by improving the blood flow using the lipoprotein apheresis. So let's talk about no option CLTI. This is a chronic limb-threatening ischemia, formerly called CLI, critical limb ischemia. We're talking about the same thing, basically severe PAD. So this is a new benchmark study. This was PI being Anahita Dua from Boston, known researcher of PAD disease. Um, so this is a very recent data, 2020 to 22. So this is the COVID years, fairly recent data. This is basically observation data. They took no option CLTI patients and they just tracked their outcome. So this is Dr. Dua as well as several other researchers, top of the field researchers in the United States. Then they just pull the results. But this is the natural history of a no option PAD, no option CLTI now. So 33 patients died within a year. 45 patients are still alive, but they lost their leg. And only 37% of patients actually have a leg and are still alive. Now, the conclusion of this study was that this is very poor, dismal outcome despite all the modern tools that we have. We have excellent wires, stents, balloons. We have amazing skilled operators and vascular surgeons. Even then, today, only 37% of patients get to keep their leg. We can do better. We should do better than this, right? So no option CLTI by definition, let's say absence of target artery. So this is the kind of radiograph or angiogram of no option CLTI. Sometimes we call it desert foot, basically desert with single S, being desert as in super dry. There's nothing there and there's no water. So the whole idea is there's no target to do any surgical bypass as well as failed EVT endovascular therapy in the last 6 months. So let's try to thread the wire and balloons in here, but you can't. It's just there's nothing there to thread the wire to. So this is no option CLTI. Oftentimes there's nothing we can do. The vascular surgeon will tell me, hey, nothing you can do. Good luck. Just watch their wounds and give them pain medicine, give them antibiotics, and see what happens. That's kind of what we're doing right now. Estimated 50,000 people incidents annually, perhaps more. A lot of people in Europe, a lot of people in Japan. This is the kind of end results of progressive peripheral arterial disease, PAD. Now, there are options though. Let's go over one by one. Leg pump, hyperbaric oxygen, DVA, and then lastly, LDL apheresis. So a pneumatic pump, I'm not going to show you the brand name, but it's essentially a leg pump, the sequential leg pump. Um, I was trained in Cleveland Clinic. We prescribe a few of these. Mayo Clinic is big on these. Basically, it's physical pump, physically pump, almost like a massage your leg, which increases the blood flow to the leg. Now, it works, but not that great. It is a medical device the patient has to purchase, bring it home, and use it their own. So the compliance is an issue. Um, Price is an issue, and the pain, it may be painful. I had one patient, a recent patient that I prescribed to. She tried it once and she didn't want to use it again because it was painful. So the compliance issue, and if the patient's not doing it, obviously it's not going to help you any. It's not going to help us. Evidence is there, but not robust. And again, that's precisely why we don't use much of this. I don't use much of this. Let's put it that way. Hyperbaric oxygen therapy. I do want to talk about this because hyperbaric oxygen and wound care is very intimate for many, many years. So we kind of go hand in hand. Now, for let's say diabetic foot wounds with an infection, with a bone infection, with a good blood flow, hyperbaric oxygen has a place in it. It absolutely helps controlling wound infection, bone infection, as well as healing the wound, preventing amputation. It works. Yes, it works. How it works is we put the patients in these chambers. pressurized with 100% oxygen. What it does is transiently increasing the oxygen in the plasma up to tenfold. So what it does is so that derives angiogenesis as well as direct killing of bacteria, controlling infection, granulation. It does a whole lot of good things. However, if there's no blood flow, again, oxygen just doesn't get there. That's a problem. Even within the UHMS guideline, if you have no blood flow, if you have a CLTI, that's not within the FDA indication or Medicare guideline for the usefulness of hyperbaric oxygen. Essentially, I usually don't bother with this if my patient has no option CLTI. And then lastly, DVA, deep vein arterialization, which is to say you connect the blocked artery to veins. You basically create artificial fistula from artery to vein within the leg. It takes about 3 months for the vein to mature and almost turn into artery. Um, we do have good data on this. This is the latest trial. It's called Promise 2 trial. They're enrolling Promise 3 trial. And the amputation-free survival was 66% on the published data in 6 months. Now, 66 is not great, but it's better than 37% that we just talked about. So this is very promising. It's still, let's say it's not widespread, but in terms of data, this is the most promising thing that we have in helping these patients who's kind of destined to lose their leg. And then lastly, lipoprotein apheresis. Let's talk about this. So lipoprotein apheresis, it looks like this. You need some kind of vascular access, almost like a dialysis, but it's not a dialysis because there's no dialysis involved. You oftentimes in my hospital, we create this what we call permacath, which is a central venous catheter line in the chest. So you can have access. You need two lines, inflow and outflow device. We treat these patients every 2 weeks. Each treatment is about 4 hours. Unlike dialysis, they do not get fatigue. With the dialysis, people often get fatigue. They cannot do much after the dialysis days. All my patients drive to the hospital, get the treatment, and drive home just fine. Very little fatigue. It is FDA approved to significantly lower lipoprotein A cholesterol, as opposed to no other medical therapy would do this to drop the dramatic drop in Lp(a). So Lp(a), lipoprotein A, is a special kind of LDL. I would say the baddest, the worst LDL you can have in your body. It is atherogenic. It predicts terrible coronary artery disease, PAD, ASCVD in general. It is hereditary. About 20% of all of us have high lipoprotein A, which you should really know. All the audience, I implore you to test yourself once in your lifetime, because it's usually stable throughout the lifetime. I just had one patient that I diagnosed with a elevated lipoprotein A. It is important for you to know, as well as for the prognostication of the disease. It's important to know that they have lipoprotein A. And again, because we don't have a really good medical therapy for elevated lipoprotein A, now statins elevates a little bit. PCSK9 inhibitors may drops a little bit, maybe 10-20% at a time, but not a whole lot. LDL apheresis, because it's a mechanical filtration of LDL and the LDL cholesterol, you will see a dramatic drop in lipoprotein A. So this is one of the factors that drives the therapeutic effect of lipoprotein apheresis. So this is how the machine works. You don't have to really know the schematics. I'm not going to quiz you on how it works. Basically, what I want to tell you is you do need some kind of vascular access. Let it be the central venous catheter on your chest, or you could have a power port in your both of your chest. Just need an inflow and outflow. That's all you need. For my use for PAD, we usually treat our patients 3 to 6 months, and we usually take out those lines because you don't need them anymore once you close the wound, once you reach the end point. So let's move on. Indications, I ask you to, so familial hypocholesterolemia is the main indication of it. The main thing that I use is the group D, the very bottom of it. I screen all my patients in hospital for lipid panel and lipoprotein A level, which is a very specific test. You specifically ask for that one. Regular lipid panel does not include lipoprotein A. I do check that for all my patients with the PAD, all my patients with diabetes in my hospital. What it does is I can tease out those patients with an elevated lipoprotein A, and if they need be, I can refer these patients for lipoprotein apheresis. So this is within the FDA indications, which was updated a little bit this year. And we've been doing this for the last 40 years. So this is a liposomal treatment center. There are 70 treatment centers, including Hawaii. So this is pretty much all the major hospital, major cities. If they have a larger cardiology department, they'll have it. Because this has been the mainstay for familial hypercholesterolemia until our recent advent of PCSK9 inhibitors. This does save lives. We've been doing this for 40 years again. This is available to you for vast majority of audience in the United States because these are all based in the city centers. And again, what does lipoprotein apheresis do for you for PAD? Increase ABI, increase TCPO2, again, by removing all those cholesterols out of your body, in the inside arteries, inside all the capillaries, even the teeny tiny arteries, it absolutely increase the blood flow, and you will see that over time objectively. Same thing with the pain level because now you have more blood flow to the ischemic leg, your pain goes down and the walking distance goes up. This is the same as plasmazole. This is the same as semaglutide trial that I showed you. By increasing the blood flow, you can achieve less pain and a better walking distance, and with it, better quality of life. Let me show you one of the more recent data. This is Dr. Kobayashi from Shonan Kamakura Hospital in Japan. He's a authority in dialysis patient research and limb preservation. They took 61 patients. Out of it is 50 patients being dialysis patients. Those are very tough patients to treat and heal. So look at the picture like that, and they treated with a LDL apheresis, and what they found is about 46% wound healed at the end of the trial, as opposed to their control only you saw about 17 patients. So he observed about 2 to 3 times more healing rate by using lipoprotein apheresis. This is another trial. This is Dr. Soga from Kokura Hospital. This is a TURNIP trial. This is a large multi-trial, multi-center trial in Japan. They took 221 patients. They treated the patients with the LDL apheresis specifically for no option CLTI, where they cannot do anything about with the wires or balloons or stents or surgically. They treated these patients with the LDL apheresis. And look at the numbers, 61.3% amputation-free survival after 1 year. Now, I remind you, going back to the Dr. Dewar paper, the 37% amputation-free survival after 1 year, this is almost double that. That's pretty good. Same with the DVA. DVA was 66% amputation-free survival after 6 months. So this is almost equivalent to DVA. Now, not to say that they compete, but they do almost achieve the same results of saving limbs, about double the number of the limbs were saved compared to not using these therapies. This is significant. This is something we couldn't do before. Now, this is kind of my own treatment, CLTI treatment pathway. So maximize medical therapy, obviously, this is kind of common medical therapy in the cardiology. High dose statins, maybe high dose statin for sure, start low and go up as long as they're not intolerant. Ezetimibe, PCSK9 inhibitors, there are 3 of them available today. Those are good strategies. So you're probably going to be adding on to see how low you can drop down the LDL cholesterol. Clopidogrel for blood thinning effect. Semaglutide, maybe if they're indicated, if they're obese, if they're diabetic, I'll absolutely add semaglutide. And silastazole, assuming that they don't have a severe congestive heart failure, I may be adding silastazole, recommending that through their cardiologist. Now, next is best practice wound care. That's where I come in. I'm a wound care practitioner, so I'll be taking care of most oftentimes I see these patients once a week, every other week in my wound clinic, and I'll be treating them the best way I can. I check every patient in my hospital with diabetes or PAD, even mild PAD. I check their lipid panel and lipoprotein A level. Lipoprotein A level, again, you probably have to check it once a lifetime. But lipid panel, you definitely want to see because you want to see where they are in terms of LDL control. If they have a high lipoprotein A, they do meet the FDA indication to refer them to lipoprotein apheresis. I wouldn't hesitate. I'll inform the patient that it is available. I refer them to the therapeutic apheresis department in my hospital, transfusion medicine department, in fact, in my hospital, and we can explore together if it's a good therapy for that. It is minimally invasive therapy, and there's no downside. None of my patients want to lose their leg, so oftentimes many of my patients are receptive to the idea. And lastly, if they have a normal Lp(a), normal cholesterol level, then you may want to consider DVA or referring them to interventionalist who does deep vein arterialization, which is probably the most promising new therapies that we have today. And then lastly, if everything fails, I throw everything spaghetti against the wall and see what sticks. I may even do leg pump if they are receptive to it. Hyperbaric oxygen, again, that's a lot more logistically intensive, but again, nobody wants to lose their leg. If they want to do it, I'll do that. TTT, tibial transfer. This is not experimental, but neurotherapy. This is the orthopedic treatment that kind of uh, this is newer therapy to create fracture in the proximal tibia, which increases growth factor, which may help no option CLTI. We don't have really good data on that, but again, I don't want to say experimental. There's FDA indication for this, but we started doing this in institution to see if that helps. Okay, let's wrap it up. So I'm gonna wrap it up with one more cases with you. This 65-year-old patient with diabetes with a forefoot gangrene. My vascular surgery colleagues went on to do tibial femtip bypass. Then I followed next day with a TMA, transmetatarsal amputation. Then a couple days later, his bypass went down. His bypass clogged. They couldn't fix it. So what ended up happening is he went home with this incision that didn't heal for 6 months. Again, for him, he was essentially no option CLTI. The vascular surgeon couldn't fix it. So I ended up seeing him weekly for 6 months. And again, eventually I just referred him to lipoprotein apheresis. And guess what? With the local wound care with the lipoprotein apheresis, he just went on to heal in a couple months' time. Amazing. That's pretty cool. So this is another leg saved, another life saved. That's cool stuff. This is why I'm here to tell you that you could make a huge difference in these patients' lives. This is the angiographic improvements before and after. I must tell you, it's subtle, but what you're going to see is that you see the kind of capillary flows and the longer filling time. Another thing that we talk about is the wound blush or blushing of the wound where the forefoot stump is. You see a more blood flow towards that direction. And by doing so, again, we are increasing the wound healing potential. And this is his lipid profile before and after. Well, actually, during the lipoprotein apheresis, before and after the treatment, we always check their cholesterol and the lipoprotein A. And again, this is what we saw, 87% reduction in lipoprotein A. and the LDL reduction maybe up to 99% down to the single digit, actually zero point 0.5. Now that's you will never ever see this with the medical therapy, even the best of PCSK9 medications. But because we're physically removing the cholesterol out of your body, we can achieve this and drive down the cholesterol. And with it, you see dramatic regression of plaques and the dramatic improvement of peripheral arterial disease. And this is the 1 year follow-up. The patient I just showed you, failed TMA, incision not healing, painful, infected. LDL apheresis went on to heal. 1 year later, he's still walking around. He's still doing fine. Again, this limb was saved from amputation. And this is the whole essence of this is what we call amputation-free survival. He's alive, he's walking around, he's back to work, and his leg was saved from major leg amputation. Pretty cool. And this is the last slide, the takeaways. So lipoprotein apheresis is FDA approved treatment that we've been doing for 40 years in Japan, in Germany, and in the United States. It's minimally invasive therapy with no pain to the patient and minimal fatigue to the patient. Uh, CLTI, amputation-free survival using the lipoprotein apheresis. The latest data I just showed you is as high as 61% in 1 year, which is not great, not 100%, but it's way better than 37% that I showed you earlier. And this is, I'm being facetious here. Hypothetically, if you take a 50,000 limbs to treat these patients, maybe we can save 30,000 limbs. I'm being facetious here, but again, if anybody listening to this and do this therapy and save 1 or 2 legs, that'll make my day. Cons, well, not so much cons. There's 70 centers in the United States. Pretty much all the major cities, all the major medical centers have this device already. FDA indication is limited. You almost have to have high cholesterol, the failed medical therapy, or high lipoprotein A patients. And the vascular access is absolutely required. There's no two ways around it. So in my institution, usually we resort to central venous catheter, power port, not power port, I'm sorry, palm cath that we place for 3 to 6 months. And then once the treatment's over, we just take it out so they can shower and they can go about their business. The bottom line, this is an under-recognized, underutilized medical therapy in the United States, despite we have 70 centers to be treated in the United States. So I urge you to look into this treatment. I urge you to proactively try to use it, and hopefully you save the leg from getting amputated. And this is the end of my talk. Thank you very much for listening. My contact information is there, and Kaneka is the device company that makes this device. You can certainly see the map of availability and whatnot through their website, through their email. Thank you so much for listening. Have a good day.